established by evidence or opinion. So that's as regards the macrovascular complications of diabetes is concerned. Now let's look at the study, an association of glycosylated hemoglobin with cardiovascular outcomes in the general population, results from so-called biomarker study to identify a novel biomarker in hemoglobin A1C to improve the cardiovascular risk assessment in general population without diabetes as well as with diabetes. The observations were hemoglobin A1C was independently associated with overall mortality, CV mortality and CV disease. This association was monotonic and not J-shaped and increased all three outcomes in diabetics and non-diabetics. As you can see here, whether it is cardiovascular mortality, cardiovascular disease or overall morbidity, the association between hemoglobin A1C and hazard ratio of CV events was progressive. As the hemoglobin A1C increased, the risk of all these three complications increased. As a risk stratification, a hemoglobin A1C more than 5.7% was particularly important. An association between hemoglobin A1C and cardiovascular death was strongest in individuals aged less than 55 years. The limitations are of course obvious. The presence of hemoglobinopathies, different ethnicities sometimes, and certain disease states like bleeding, transfusion or hemodialysis can interfere with the measurement of hemoglobin A1C. Other is in those less than 55 years of age, a hemoglobin A1C more than 5.7% is considered a high risk for development of cardiovascular disease. Now this is yet another study which had a meta-analysis of 46 studies, found an increase in the risk of all-cause mortality in diabetics as well as non-diabetics. The cutoff point for increase in mortality in diabetics was more than 8% and in non-diabetics more than 6%. Likewise, diabetic with less than 6% and non-diabetic less than 5% hemoglobin A1C also had higher all-cause mortality. So the inference from this group of studies is that hemoglobin A1C is a reliable risk factor for all-cause and CV mortality in both diabetics and non-diabetics. Optimal hemoglobin A1C levels for the lowest all-cause and cardiovascular mortality ranges from 6 to 8% in diabetics and 5 to 6% in non-diabetics. The study also emphasizes the clinical importance of preventing hypoglycemia in diabetics. Hemoglobin A1C may therefore be included in the algorithms to calculate CV risk factor in the clinical setting. This is yet another study which estimated the glycosylated hemoglobin in relationship to cardiovascular outcomes and death in patients with type 2 diabetes. It found that each 1% increase in hemoglobin A1C was associated with 17% increase in the incidence of cardiovascular events. As far as those without known diabetes, hemoglobin A1C levels above 6% was associated with a 20% risk of CV events. So physicians should consider including hemoglobin A1C as yet another biomarker for the risk assessment of cardiovascular risk in diabetics as well as non-diabetics. Now this is a study where hemoglobin A1C levels and the risk of cardiovascular disease in people without known diabetes was carried out, and you will find the hazard ratio for CV events according to continuous hemoglobin A1C levels without known diabetes also showed a similar trend. The findings were both high and low levels of hemoglobin A1C were associated with an increased risk of cardiovascular deaths among participants without known diabetes. Association between hemoglobin A1C and CVD risk was non-linear. Low levels of hemoglobin A1C were associated with an increased risk of stroke, especially hemorrhagic stroke, while diabetes and high hemoglobin A1C levels are associated with an increased risk of coronary heart disease and stroke, especially ischemic stroke. Low hemoglobin A1C levels are also associated with an increased risk of all-cause mortality in people without diabetes. So data support the notion that a very low and very high levels of hemoglobin A1C may be markers for identifying people with increased health risk. Now looking at the difference between men and women, this study shows that among men, hemoglobin A1C at all levels, whether it is normal, pre-diabetics or diabetes, was associated with an increased risk of cardiovascular diseases. Whereas in women, CVD risk was restricted to those with hemoglobin A1C level equal to or more than 6%. That is only in pre-diabetes and diabetes and not those with normal glucose tolerance. That is, one should optimize the CVD risk factor management at all levels of glycemia in men more than women. So to summarize, hemoglobin A1C is being used to diagnose and monitor diabetes and other categories of glucose intolerance hitherto. It is now emerging as a new and novel risk factor for heart disease and other cardiovascular diseases, conferring a new third dimension to it. This association is seen in diabetics and non-diabetics. The cutoff point in diabetics is more than 8%, while that in non-diabetics is more than 6%. Some studies have shown a J-shaped relationship in that a hemoglobin A1C less than 6% in diabetics and less than 5% in non-diabetics is associated with higher CV and all-cause mortality. This emphasizes the importance of preventing hypoglycemia in diabetics. Optimum level of hemoglobin A1C for preventing cardiovascular and all-cause mortality is 6 to 8% in diabetics and 5 to 6% in non-diabetics. Each 1% increase in hemoglobin A1C increases the incidence of cardiovascular events by 17 to 20%. There is a gender difference in this association. Hemoglobin A1C should be included in the risk assessment algorithms for cardiovascular diseases as yet another novel biomarker. The carry-home message is very simple. Today, hemoglobin A1C is emerging as a novel biomarker to improve cardiovascular risk assessment in general population on par with serum cholesterol, blood pressure, etc. Thank you very much. Thank you for a patient hearing.
6 to 8 is the cutoff you have told, sir. But even 7, 7.5, 8 also has more of cardiovascular risk in HbA1c, sir. But you are giving the upper limit up to 8%.
Yeah, that's what exactly long term, especially below 55 years of age. Below 55 years of age.
But there are a lot of papers.
You should try to keep it less than 8, less than 7, preferably. Up to 8 is still okay.
Less than 7, all right, sir, but cutoff was 8, sir.
This is a long-term study on enough thousands, not thousands, 10,000s of patients.
Right, sir.
Now this is for macrovascular disease. You must understand that. Because we know for microvascular.
I think you take with a pinch of salt as a marker of A1C to judge the cardiovascular outcome. I think it's a more of combined risk factors of not only diabetes, also the smoking, dyslipidemia, obesity, sedentary lifestyles.
These all based on after other things have been excluded. How will you now react to your HSCRP?
Quite possibly, I tell you the studies, ACCORD studies, all those who try to control the A1C to a very tighter control in the elderly population, they fail. Probably the message may be that the A1C, if you try to keep it less than 6 in elderly population, may have a hazardous effect. But I don't know whether we take A1C alone as a marker for cardiovascular.
No, he said
A1C is one among them.
We
but
say it is one other marker. We didn't say this is the only marker. Now, this topic itself is new. In fact, that is precisely why I wanted to talk about this. This particular concept is new. You won't find it ordinarily. Now, with this idea, you go and refer and read, you will know that this is emanating as a newer marker, sir, one other concept.
Yes,
now, you know for sure there is a linear relationship between cholesterol and cardiovascular death. Hypertension or blood pressure on cardiovascular, but we never thought that this is also a marker continuously for cardiovascular death, because that's what I said. Before 1970s, we did not even know that diabetes is associated with heart disease.
Yes,
now that we know, this is also coming as one other thing where you have to look up. So when you write down age, sex, smoking, cholesterol, BP, now you add hemoglobin A1C and not diabetes. That's what exactly it means.
But sir, we all understand that, sir, but A1C at 8, that's what we are asking.
Preferably less than 55.
Less
you know,
than
most
7.
of your patients are stuck at that time.
Sir.
Yeah, there is one other thing. That's what I'm saying.
So one thing, no, that what we have seen in UK PDS, over 15 years of follow-up in UK PDS, any reduction in HbA1c has been associated with reduction in cardiovascular disease. Like, in the 15 years, what has happened was that both the control arm and as well as intensive arm, both have upper limits of more than 8 HbA1c.
Not macrovascular,
No.
Vijay Kumar.
No, for macrovascular disease, sir.
Not macrovascular.
That is macrovascular disease I am talking. Just 0.9% reduction, the difference of HbA1c is associated with 18% reduction in cardiovascular disease. Any HbA1c reduction is very useful. That's one thing. Sir, one more thing, sir, the new concept we have discussed one of our journal clubs, like glycemic variability, there is one thing called as HbA1c variability. So we need to keep the HbA1c constant, as Hariharan is telling, it should be constant. One time it is 7, one time it is 9, one time it is 6.5, it doesn't help at all. It's a constantly reduced HbA1c is the most important thing. They call it HbA1c variability, which is a new concept.
Sometimes you can have a normal A1C, but if you look at the ABG profile,
That's known, sir. That is known, sir.
That is
yeah,
known.
that's what the glycemic variability may be a better marker than A1C.
Yeah, that is known. That is
No,
why
but
it's
what
already
I'm talking is
addressed,
HbA1c variability. That also is very important.
Because of glycemic variability, HbA1c variability. Right, sir. Thank you, sir.
Thank you, sir.
Thank you.
As usual, wonderful talk.
All I want to emphasize this is a new area. This is a new thing that is coming up. Whenever something is new, nobody is going to agree. Over time, everybody will come. Thank you.
Thank you, sir.